Welcome to our monthly webinar series hosted by the Office of Integrated Healthcare Research and Policy in the Department of Family Medicine at the University of Colorado School of Medicine. Let me begin by telling you a bit about our sponsor and partners. This webinar series is sponsored by the California Mental Health Services Authority Integrated Behavioral Health Project. CalMESA is an organization of county governments working to improve mental health outcomes for individuals, families, and communities. Prevention and early intervention programs implemented by CalMESA are funded by counties through voter-approved Proposition 63, the Mental Health Services Act. The Agency for Healthcare Research and Quality, Academy for Integrating Behavioral Health and Primary Care, functions as a coordinating center and national resource for people committed to delivering comprehensive integrated care. The Academy focuses particularly on integrating behavioral health into primary care practices and promotes a collaborative environment that fosters dialogue among leaders and other stakeholders in integrated behavioral health and primary care. Key Academy tasks include the National Integration Academy Council, an expert panel of nationally recognized leaders in integrated healthcare, the Academy web portal and literature repository, the recently developed lexicon for behavioral health and primary care integration, and much more. The Collaborative Family Healthcare Association is a nonprofit, member-driven collaborative organization in existence since 1995. CFHA promotes a comprehensive and cost-effective model of healthcare delivery that integrates mind and body, individuals and families, patients, providers, and communities. Advancing Care Together, a project at the University of Colorado Denver Department of Family Medicine, is a 4-year program aimed to discover practical models to integrate mental health, substance use, and primary care services. The program, funded by the Colorado Health Foundation, has funded 11 demonstration projects that have been organized as a set of diverse comparative case studies and will be linked to support cross-project learning. Before introducing our presenter for today, I'm going to quickly go over a few housekeeping items for GoToWebinar. If you see the GoToWebinar control panel on the right-hand side of your screen, you can select the audio through either your telephone or microphone and speakers of your computer. And there's a feature underneath where you can ask questions through chat. So please submit your questions throughout the presentation, and at the end of the presentation, we will answer any of your questions. Also, the webinar will be recorded and posted on our YouTube channel, which the username is CUDFM Policy Channel, and that's listed on your screen as well. Today, we are pleased to bring you Dr. Talmi. Dr. Talmi is an associate professor of the Department of Psychiatry and Pediatrics at the University of Colorado School of Medicine and practices at Children's Hospital Colorado as a pediatric psychologist. As the director of the Irving Harris Program in Child Development and Infant Mental Health and the associate director of the Center for Family and Infant Interactions, she engages in training and supervision of postdoctoral fellows, interns, externs, health and allied health professionals, and others at the University of Colorado and throughout the broader community. As the program director for the Project CLIMB, Dr. Talmi developed, implemented, and currently administers an integrated mental health and behavioral services program in a high-volume pediatric residency training clinic. The program delivers services to over 2,500 children annually and trains pediatric primary care providers to better address the developmental and behavioral health needs of children. Her primary clinical and research interests focus on infant and parent relationships, young children with special health care needs, service delivery systems for children and families, and integrating behavioral health services into primary care settings. She has authored numerous publications. She has extensive experience training medical and allied health professionals on neurodevelopmental interventions for children with special health needs. Today, she will discuss integrating behavioral health services into pediatric primary care settings. Welcome, and thank you so much for your presentation today. I'm going to pass the screen over to you.
Great. Is it up?
Yep.
Okay,
Perfect.
great. I'm going to move the control panel so I could see. Good morning, everyone. I'm used to looking out and seeing people when I present, so looking at my own computer screen is a little bit different. Please do type in your questions as I go through the presentation, and I'll be sure to stop so that we have plenty of time to answer those. This is the title of my presentation, and I'm going to move the slides. I don't have any financial disclosures to make this morning. I want to start by just spending a moment talking about yet another tragedy, another school shooting, and again in Colorado. And I want us to just take a moment to recognize that events like this are tragic. Our thoughts are with the victim and really with all of the students and families and teachers and staff that have been affected in our state and nationally by violence in the schools. It's been a particularly traumatic time here in Colorado, and was especially poignant on the eve of a massacre that happened in Connecticut a year ago. And I'm going to be coming back to this because it's something that we as mental health professionals in pediatric primary care settings are faced with, these unanticipated community level events. This morning's objectives are to identify the opportunities for delivering integrated behavioral health services in primary care settings, and I especially want to talk about common barriers and challenges to delivering these services, identifying resources for you as professionals working in these settings, and also have a little bit of time to describe the program that we have here, again, as a model and for consideration for resources and opportunities. The first thing that we want to establish is that pediatric primary care is one of the right and probably best settings for pediatric mental health and behavioral health services. And it simply works because of the volume of visits. Children and their families come to pediatric primary care settings, and in some communities, obviously, to family medicine settings. So really, primary care is the right place. And if you look at the number of visits, and then you start looking at the number of well child visits, it's 34 million visits per year. And an important thing to note is that within the first 4 years of life, when families are really beginning to establish relationships with primary care providers and with health homes, there are 11 visits. 7 of those visits are recommended in the first year of life. So we have a real opportunity in primary care settings to see a lot of children from the time that they're born, to see them frequently over the first few years of life, to really establish strong relationships with primary care providers, and for us as behavioral health specialists, with us and our teams. And if we look at the changing landscape of disability in childhood, and you'll see the reference for this chart on the bottom of the slide, and you look at the prevalence of different conditions and limitations in usual activities because of these conditions, the first 4 conditions, actually 5, really have to do with mental health, behavior, and development. And that's a pretty profound statement. We know that only a fraction of children who have impairments in functional abilities and in tasks of daily living actually ever make it to traditional mental health settings. But the vast majority of these children are seen in primary care settings. There's been a tremendous push and spotlight and effort from national associations like the American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry to advance this idea of collaborative care. And the American Psychological Association has also been spending a lot of time thinking about how to improve our collaboration with the need for early detection and prevention of mental illness, and the frontline need for pediatric and other primary care health professionals to be able to identify and address common behavioral and mental health issues, because there is a tremendous shortage of available, accessible mental health services in the community that families would be willing to actually take on. When we look at the American Academy of Pediatrics Bright Futures, this is a developmentally based approach. I have the website listed at the end of the webinar so you can take a look at their resources. But the 2008 edition really emphasized mental health screening, and mental health screening very early in development. So long before even those of us who are child clinicians might think about doing screening, to really start asking about these issues: social emotional development, mental health, and family well-being, even as early as the 1-month visit. And really emphasizing the essential need for developing workforce capacity for pediatric health professionals so that they are competent and confident when addressing mental health and behavioral issues. And again, a little bit more on Bright Futures. And as a mental health professional, this is not something that I necessarily would have been trained in prior to being in a pediatric primary care setting, but really the charter principles spoke to me and speak to those of us that provide these services. And I highlighted in red here the idea that mental health and mental health services provided in the context of an ongoing continuous relationship with primary health professionals or teams is really critical to promoting population health and well-being. And to thinking through what we're doing in our primary care settings when we provide behavioral health services, how they focus on not just the child who's coming in for the visit, but on the family and the child's environment. There are also guidelines for health supervision visits from the American Academy of Pediatrics, and again, highlighted in red are the elements of these guidelines that really speak to us as we think about behavioral health services for children and families in primary care settings. The idea that the relationship between the practitioners and family members is a critical component is something that, again, for those of us who are trained in traditional mental health services, we may not necessarily have been trained in or thinking about promoting relationships with other health professionals. And in our program, when I describe it, I'll talk about how we really work through the primary care provider and sometimes don't even see the family as ourselves. It's important to also remember that all of the work for behavioral health, sorry, I thought I turned that off. All of the work for behavioral health is done in the context of a medical home. This has been described as health homes, health neighborhoods. We're talking about healthy communities also, but that these are the components that have been advanced around medical home, and that the services that we provide, and when we're building programs and delivering these services, that they are patient-centered, they're comprehensive and coordinated, and that they're accessible and of high quality and safe. And you can read these definitions yourselves, but in building the program that we've developed, these principles have really been at the core of thinking about how to develop an integrated behavioral health program. This is an important resource for those of us who are interested in what other people are doing. This is the APA and AAMC have expanded mental health education resources. And just from this past June, I won't read this to you, but if you have a chance, I would highly recommend that you go on the iCollaborative website and look at some of the information that's on there and the resources. It also has some really nice program descriptions. So what do we do in pediatric primary care? If you look at the list of all of these different things, from screening and identification to diagnosis and treatment, triage and referral, environmental interventions, None of those look particularly different than what we might do in our traditional outpatient or even day treatment and higher level of care mental health settings. But when we think about how these different components of mental health and behavioral services and treatments get done, they actually look quite different in primary care settings. And the second column really speaks to prevention, health promotion and adherence, and then getting to the idea of strengthening families, teaching training, and developing workforce capacity, and then for us really thinking about how we develop comprehensive systems of care that are inclusive of access to integrated behavioral health services in primary care settings. And in family medicine, this is a given and it's accessible and available. In pediatric primary care, while some of these activities are absolutely the norm, the idea of having integrated behavioral health specialists is still relatively new and presents with a number of challenges. And so going from the last slide to what do we do in primary care, we can really think about a model where we certainly are providing universal preventative services, and this has a lot to do with activities like screening processes, identification of families, offering anticipatory guidance on common developmental and behavioral health issues, and then thinking about another layer of the second layer of really focused services. And these may be for at-risk populations. So for example, screening for pregnancy-related depression and then providing services around the results of those screenings would be a focused service because you've identified a population that's at risk, or in some cases, the populations that we serve in our pediatric primary care settings are really vulnerable populations with maybe limited access to community-based mental health services or family support services. And so thinking about incorporating some services that are targeting at-risk populations, but then also in our pediatric primary care settings with integrated programs, we can actually provide higher level services that look more like what we might be doing in community and outpatient community-based mental health services. And so the boxes around this very busy slide really show some of the programs that we've developed or have implemented at these different levels to help us provide a comprehensive program and access, much greater access. And then outside of the levels of service, we have a lot of work that needs to be done in terms of policy at the local level and at the state level, and hopefully I'll have a chance to talk a little bit more about that. And really, if you take that last slide and you think about the opportunities for intervening in pediatric primary care settings, it gets back to Bronfenbrenner's human ecology model and really thinking about children coming in to primary care services. They generally don't come in by themselves. They come in with their families, and we interface with them at this layer and really do have a lot of opportunity to intervene and to think about what the needs are, identify difficulties, and from primary care be able to serve this system. And then thinking about, as I mentioned, community violence or school shootings really would impact who we're seeing at this outer level. But anything that is happening at any of these levels, whether it's within the individual or in their immediate circle or something that happens at the community level, is very likely to be impacting behavior, development, and child and family well-being, and therefore becomes something that we would need to address in a primary care setting. And if you look at, this is from the Strengthening Families website, it's the same model. And again, thinking about child and family well-being. So we identify a lot of issues and problems as integrated behavioral health specialists, but we also have the opportunity to build capacity, to enhance protective factors, and to reduce risks. And when I think about how to measure the outcomes of the work that we're doing, it's much easier to quantify who we serve and what we're doing with them than to think about the long-term outcomes. But I thought the Strengthening Families, the 5 protective factors that they have really put forward for us in pediatric primary care matter a lot, because the social and emotional competence, the well-being of children, is really dependent on family well-being and on community and environmental well-being. And so I would challenge all of us to think about how we're measuring these protective factors and how we're incorporating these protective factors into the work that we do, into the programs that we build. I've already touched on some of this a little bit, but really wanted to highlight, and I often feel like this is stating the obvious, but it's in stating the obvious that we really get at the barriers and the challenges and the opportunities of pediatric primary care. So I think the first question in pediatric primary care is, who is your patient or client? And that is a complicated question to answer, because obviously it's the child, and often it's who brings the child to the setting, but very often it's also who's not in the room. And then the other element of this is that we have a layer of clients that have to do with the other health professionals that are practicing in these settings with us. The second question of what's the diagnosis is a tricky one to answer, because sometimes it's very clear cut, there are diagnoses, but lots of times if we're doing health promotion and prevention activities in the context of routine well child care, we really don't have a mental health diagnosis. And this makes it very complicated for documentation and billing in some cases, which is a later question. What services do you provide, and who gets these services? So we have been faced in our own clinic with challenges around people in the community knowing that we have an integrated behavioral health services team and wanting to refer their patients who are receiving primary care services in other settings to our setting for second opinions. We don't do that, because that actually just sets up a mental health clinic within our primary care center. We provide services, and each program really needs to establish these criteria for themselves, but we provide services only to patients that are receiving primary care services in our setting. How do prevention and health promotion services get provided is a really complicated question, particularly when our services in part have to be driven by the type of revenue that gets generated, and then documentation around behavioral health services. And I think for me, as someone in an academic medical center, thinking about training and workforce capacity development, it really isn't enough to have good child and family training or to be a generalist. There are big differences working in healthcare settings, and what are the skills and what are the conversations we're having with our colleagues around developing those skills? What are the tools that we need? What would we build as a toolkit for ourselves as integrated behavioral health professionals? I'm sure you're all familiar with collaborative care levels, and I want to point out that there is a big difference between co-location of mental health professionals in a primary care setting and having an integrated program. And although this definition, which does not come from us, includes in the integrated collaborative care co-location, it's beyond having access to somebody's schedule or template to book outpatient appointments. When I say integrated behavioral health services and really think about this highest level of collaborative care, I'm talking about being in the same setting as the primary care professionals and offering services in conjunction with those appointments that are scheduled in primary care. So not necessarily having a separate schedule from somebody who works closely with the primary care clinicians, but ends up having 28 hours a week of their time blocked to do therapy, which is a model that is certainly more fundable, but is really different than full integration. And we actually just recently published a survey of in academic pediatrics of pediatric residency programs, asking what their current practice and availability was. And what you'll see is that more than half of the programs really reported this traditional care. And the integrated care was only about 13%, but 22% of the programs had access to mental health professionals. Oops. I'm going to spend a little bit of time describing our program so that I can illustrate some of what I've already talked about. It's called Project Climb, and I want to acknowledge our funders throughout the years. We would not be in operation today if we did not have grant funding, and the initial grant funding that we got was really for direct access to care for a vulnerable population of children and families who were not getting appropriate community-based mental health services, and then for teaching and training pediatric health professionals to better identify, treat, and triage common mental health, behavioral, and developmental issues. And since then, we've been able to leverage funding and become much more sustainable. And the grant funding that we have now really is used to implement new programs. And I'm going to point out one, Climb to Community. We're actually in the process of doing a second round of pilots in community-based pediatric primary care clinics to look at billing, reimbursement, and sustainability issues, because for a variety of reasons in our residency training clinic, that's been harder to do. We have different billing and reimbursement challenges here. The Child Health Clinic is located at Children's Hospital Colorado. It's a large teaching clinic, and actually we used to be part of the main hospital. We had a lovely clinic on the first floor, and just about a year and a half ago got moved across the street. And that doesn't sound like a far distance, and it's about a 7-minute walk, but the move across the street now has us operating like a community pediatric clinic. And so that's been an interesting experiment in what it's like to access resources. So for example, even emergency care and escorting people who might need to go to our emergency department for a psych evaluation has become an entirely different process, and we've had a variety of risk management issues in even getting our patients across the street to our own emergency department. The clinic sees about 23,000 visits a year, and I want to point out that common to pediatric primary care settings is that many of the well child visits are happening in the first 3 years of life, and so we have a very large early childhood population, which again necessitates a certain skill set and integrated behavioral health professionals who are very familiar with early childhood development and early childhood mental health issues. And we have a large Hispanic population, and about 40% of our families report that Spanish is their primary language. And then when we moved across the street, we actually had an opportunity to go to a pod-based clinic design, which I'll show you pictures of in a moment. I want to acknowledge that our team, if I actually wrote down everybody who has worked with us, would take slides and slides and slides, and that is because we have a large residency training clinic, and that middle column here, the and many more, I think I stopped probably after the third year of our project listing the residents, and I couldn't even list everybody who had been there. But it really does take all of us working together and thinking about how we're going to deliver the services and how we're going to deliver the training and education that's necessary so that we have cohorts of professionals who can collaborate and work together. And all of this work that I'm going to be showing you from here out could not have been done without the investment and engagement of each one of these professionals. So this is what it looks like when we're in clinic. And here, this picture, you see one of our integrated behavioral health specialists, a psychologist, going over a developmental screening with this mom and little girl. And we have been very interested in developing screening processes. I'll show you some of the data from that, and in really thinking about how we communicate information about screening, not only back to families, but also to our pediatric health professional colleagues, and how we build systems where screenings and referrals are actually resulted to the same level and with the same standards that other orders and labs and referrals get resulted. And that's been a real struggle and also an opportunity. This lower picture you see here, one of our medical assistants spending time with families, with young children in the waiting room. And for us, it's been really important to engage staff at all levels, so not just our integrated mental health professionals, but to have a team of providers who think about mental health and well-being from the moment that families walk into clinic. And then in this picture, you see one of our pediatric residents who's now an attending in the emergency department at our hospital, physically examining a 3-year-old boy. And what you don't see in this picture is that this little boy came in with his mom brought him in, and the presenting problem was that he was experiencing severe distress. And the reason for that distress was that the week prior to coming into the primary care clinic, he had been left on a preschool bus. He had fallen asleep in the back row, and the bus driver, I guess, checked the bus to make sure nobody was on it, but didn't go all the way to the back of the bus. And this boy was on the bus by himself. It's not clear when he woke up, but the driver left the bus and the little boy wasn't found for 3 hours. And so, needless to say, he was incredibly distressed, and his mother came in saying he was refusing to separate, was refusing to go to school, and every time he saw anything that looked like his little yellow school bus, he was freaking out. So we had one of our behavioral health specialists go in with the pediatric resident. We talked about what had happened, and this behavioral health specialist made some really nice recommendations to help get him transitioned back to being able to separate from mom, to talk about the experience, to tell his story. And this required a couple of follow-up visits, but within a month, he was no longer experiencing the levels of distress that he had been experiencing, and his mother was able to really provide support around this event that had happened. And so these are the kinds of programs and services that we have. I've already mentioned developmental screening. We also screen for pregnancy-related depression. We are a Healthy Steps for Young Children site, and we are also in Colorado implementing Healthy Steps, expanding our program in our clinic, but also implementing it and expanding to new programs statewide. We have a group-based well child visit model called Baby and Me. We certainly provide case-based consultation, and that example that I just gave you of the little boy who got left on a bus is exactly what we would do when we're available in clinic. We do care coordination, triage, and referral, and really support the pediatric health professionals and primary care providers to do that for their families. We do psychopharm consultations, counseling and brief therapy services, so things that we can address within the context of primary care. We really try hard to do so. And then I already mentioned the Climb to Community project and a lot of emphasis on training and education. This is a slide that shows our program growth over time, and you can see our first year that we started, it was really me, one trainee, and when I say me, I mean very part-time, so I think I was in clinic 3 half days a week, and there was a psychiatrist who was there 1 or 2 half days a week, and we had a trainee that was there for 2 half days a week. And so you can see over time that we've really been able to expand the number of consultations that we do and also to serve more unique families. Many of our families come in for more than one visit, and so that's why there's a discrepancy between the number of patients and the number of consults. We also do a lot of developmental screening. I won't go into that in detail, but we've spent a lot of time thinking about screening processes and improving that, and actually using some of what we learned from developmental screening to really think about how we can improve other screening processes. I wanted to show you the different types of consultations that we do and to look at them specifically by age group. So that you can see what we were really interested in was, were we providing distinct services, and could we tell the difference when we were saying we were doing a developmental consult versus healthy steps or a psychopharm consult. And you can see in this slide that indeed we are doing maternal depression consultation appropriately for the birth to 3, and really if you look at this over the first 6 months of life, it's we screen at every well child visit or every clinic visit and up until 4 months. And so you can see that that's where this is happening. And in contrast, when we look at our psychopharm visits, those are really happening with the psychiatrists for the 6 and up population, which is very appropriate. We do a fair amount of mental health consultation across the board, but that traditional type of consultation, case-based consultation, is most prevalent in the 6 and up age range. We also we have an electronic medical record, and we've been working for years now on how to understand our population, understand where we have service gaps, develop new programs, and look at some quality issues. And so I wanted to show you again by these 3 age groups. This is just of the consultations that we've done, which medical diagnoses are most prevalent and which of the psychological or psychiatric diagnoses are most prevalent. And what you can see is that in the birth to 3 population, we are primarily seeing, and these are the diagnoses on the medical record, we are primarily seeing children for well child visits, and we continue to see them as they get older, but that frequency decreases. And things like feeding problems are much more prevalent in the early years, whereas weight issues and asthma we end up seeing in the school age population more frequently. When we move down to the psychological or psychiatric diagnoses, we see that very few of them, except for things like developmental delay, really appear in the first 3 years of life. So if we wanted to use traditional mental health billing, we would not be able to do so on the basis of these services and these diagnoses, whereas things like ADHD really are being reported and diagnosed only in our 6 and up population. We also ask our clinicians, our behavioral health specialists, to identify what the problem was that they were working on, and these are the different types of consultations. So if you look, our Healthy Steps program, really the type of problem is not a problem at all. It's that we saw them for typical developmental issues. In contrast, again, our psychopharm consults, we see a lot of ADHD. And then behavior problems end up showing up, family issues end up showing up in these mental health consultations, but really in the developmental consults, mental health, and in the psychopharm consults, we're seeing across, not fewer in the psychopharm consults. The family issues are really coming up in developmental, in healthy steps, in mental health consults, and in maternal depression. And that's important to know about our population and to think about as we're developing programs. These are the types of recommendations that we make, and I'm just going to point out here that these blue bars are follow-up with our program. And in the vast majority of cases, because we are building a relationship with families and it's in the context of their primary care services and in the medical home, we ask them to come back and follow up with us. And it's done typically in the context of their next visit, but we often will request a follow-up sooner so that we can make sure that other things have been addressed. And then you can see the pink bar is outside referral to mental health services, and that certainly does happen. We have some access issues and a lot of barriers to getting our families into services in our community. And this is what it looks like. And so you can see the pods. This is our licensed professional counselor, Kathy, who sits in green pod. This is kind of her space. And this is Kristen, who was a postdoctoral fellow with us last year, and this is one of the residents. And you can see the attending is here, the nurse is here, and we have more residents and an MA, and so everybody is really working together in very close proximity. I'm just going to quickly go through healthy steps, and I've already mentioned that we do it. You can get a lot of information about healthy steps from the website, and it's been our way of providing services for the young children who are being seen for well child visits who don't have a mental health diagnosis, and where we're trying to enhance development. And as I mentioned, we're using McV funding to really expand the program, not just in our clinic, but across Colorado. We did a content analysis of well child visits to look at whether there was a difference in what got talked about at the doctor's office. And indeed, when there was a healthy steps specialist involved with the family, all of these topics that you see listed here, which are all topics that are supposed to be covered during well child visits, got talked about more frequently. And we thought that this was pretty powerful because even under the best of circumstances, a primary care visit for a well child visit is on average 18 minutes long, and there is just no way to cover everything that needs to be covered. But when we have enhanced programs and integrated behavioral health specialists, they can really help address what's at the core of anticipatory guidance and health promotion and prevention. And then this is a picture of our Baby and Me at the CHC group. This is actually from their very first group. This cohort, and it's not all of the families that are in the cohort, but this cohort is turning 1, and we're having their 1-year birthday party and last group visit on January 9th. And it's been an incredible opportunity to think about how to deliver anticipatory guidance around social emotional well-being and family well-being, and then have them have the continuity of care in our clinic with their providers. I mentioned that we screen for pregnancy-related depression. Sorry. And so we do that. We have been working on providing services to the extent that we can within our clinic, and that has been really, really critical for us. One of the hesitancies that we had with our providers was that they did not want to be screening for pregnancy-related depression and not have anything to do about it. And in Colorado, we recently, very, very recently, published these pregnancy-related depression symptoms clinical guidelines. It's actually a 2-sided document that has some wonderful resources with the intention that we would promote and encourage and support screening for pregnancy-related depression much more universally than it's currently happening. And if anyone is interested, I'm happy to figure out a way to get you this document. And then we have a lot of other resources that are published. There are toolkits from the AAP. We have information on the mental health side through APA. This is from Foy's article, and it's a little bit hard to see, it's blurry, but it gives an algorithm for what to do in order to promote social emotional health, and I would encourage you to look up this article. It's a very useful algorithm. And then I've talked about our integrated care and teaching. That workforce capacity development is so central to what we do. And here's just an example. So talking about pregnancy-related depression, we implemented screening, developed an entire module and curriculum for the residents to use and other health professionals, and then we did trainings, and we used pictures of the residents that were there when we developed this and gave them the words to use in doing this work. So these are some additional resources. I would like to show you a pretty short video. I know we're in the question and answer period, but I just wanted to show a quick video of a mom who talks about her experience in getting these integrated behavioral health services in our clinic, and I'm hoping that's okay. Emma, you will tell me if that's not okay.
That's fine.
Okay, thank you. I'm just going to go to the video.
It was real exciting to know exactly what was going to happen, but I felt comfortable because I had, instead of one person I like at the NICU when he first came, I had a whole lot of people that were letting me know what was going on. So that automatically just let me know that this is where I needed to be, because it was a whole lot of people instead of one that was helping me out as far as what was to become of my situation with him. So they gave me, you came in, you gave me sheets, and then I had the lactation, and it was just, I had stuff going in all different directions. So it was nice. It was really nice, especially with the deal that I had been through. Comforting to know that I can look in 4 different ways, and I got help in every different way with different specialists. So it was different, and it made me feel comfortable to know that I got help in every different aspect. So,
was it a different experience to have someone ask you how you were doing and Dad?
Oh yeah, yeah, because mostly the attention's always on just the baby, and I felt like, for you guys to ask us like, "Are you okay?" It made me feel good, because a lot of people don't get to express themselves, and that's when you could go home and like but when you guys asked, it was good. It was very good. It made me feel better, willing to open up to express how I was feeling, because some days were not good, and some days I didn't feel good and I was depressed, but I was able to get strategies and say different things, and it worked out. Yes, it's like a big family. It's a really big family. I think this is probably like the best care, and then you were very, very, very good help to me. Yeah, that was exciting to be able to have you, because a lot of people, forget things, and once the doctor comes out and they're gone, you're like, so you're like, is there anything you forget? And I'm like, oh yeah, and then you feel it right back in. So that's also a good thing, which I never had before.
So it sounds like it was helpful for you guys to have a child development stay in the visit.
Exactly, because also some people are uncomfortable with telling doctors things. I've been through things like that before, and that they might want to tell somebody else, so they always know that they got a second person to go to. That's really good.
I don't think I could ever articulate it as well as that mom does. So Emma, are we ready for questions?
Yep. Okay, just 1 second. Okay, so first question. I'm curious to hear your thoughts about what core competencies are important for your fellows to have after they leave the program, specifically core competencies for the community and state levels in your work of pediatric primary care.
I think it's an excellent question. It's been interesting to think and focus more on the training of pediatric health professionals while at the same time supervising and training the behavioral health professionals that are working in these clinics. And I think not unlike working in other health settings, there is absolutely a basic need to be able to operate within health systems, to be able to collaborate and really understand the particular clinic and setting that you're working in. And I find that it's rarely the specific clinical skills that the behavioral health clinicians need, and much more about finding their place in the setting and learning how to navigate the health care environment so that their work becomes relevant. And so I think it's, instead of a particular book to read or even topics to know, I think having really good basic clinical skills, including things like motivational interviewing and understanding screening processes, that's one piece of it. I think then there's the being able to collaborate with our healthcare partners to make the work that we do relevant and to fit into whatever that healthcare setting is needing. And each of the two fellows that we actually have in community are having quite different experiences because the clinics that they work in are so different. So I think that that's really important. And then the other piece of it, the policy piece, I think is critical to be thinking about. So in our program, we bill and document and have made tremendous efforts to get information about the work that we're doing, despite the fact that we have not gotten any revenue from the healthcare system, and we have a primarily publicly insured population. And the importance of that billing and that documentation and of being able to find our place within the healthcare system is the advocacy and policy work that I think is part of those core competencies.
Great, thank you. And we've received a few questions related to billing, which you've spoken to. So I'm going to ask and see if you have anything else to add. What behavioral codes do you bill? How are they reimbursed? In our clinic, we have to pre-certified mental health visits. So do you get these visits pre-certified?
So billing is really complicated, and it is even more complicated by the fact that I work in Colorado, where health and behavior codes are not reimbursed by Medicaid. So we bill health and behavior codes when there is a medical diagnosis that we're seeing the children for. Those have never been reimbursed, but I have a lot of data on what we bill and what we see. We've been working with our billing entity to think about other mechanisms for billing. If we build mental health codes, we would not in Colorado need a pre-auth. So that's one barrier that has been eliminated. I just met with one of the medical directors of one of our behavioral health organizations, and he assured me that I, as a psychologist, could diagnose, or have, if somebody had a diagnosis of ADHD, I could bill for that diagnosis and the services that I was providing. The issue that we have is that we have trainees who bill who are not credentialed with our behavioral health organizations, and we have capitated mental health, as do some other places. And so that makes that billing challenging. What we are trying now with our Climb to Community project is actually using, and I don't have any data, I'm supposed to get data on Friday, we just started this project in mid-September, but we are actually trying to use counseling codes and modifiers that the primary care providers are submitting with our fellows billing under the primary care providers as physician extenders. I know that in Colorado, one of the very successful practices in having co-located mental health services has been able to use the incident to billing. So that's one strategy. I do think that billing issues are very unique to the state that you're practicing in and the setting. And so if you're doing traditional mental health services, the pre-auth requirement really makes it very hard in many settings. In Colorado, it happens to work, but it is not the kind of model that we're trying to espouse. We also have some preventative codes that were just sent to me. I'm struggling with whether or not we could use them. And then I think the other piece that's really important to this work is that billing in mental health works when there's a diagnosis, and the vast majority of the work that we do is for the children who and families who don't have a diagnosis. You also get into two-generation billing. So in pediatric primary care, we're not registering the families and the caregivers, and if there's a mental health issue that lives in the parent that's impacting the child's well-being, we can't bill for that.
Okay, next question. Do you see all patients with the medical team, or do you see some patients after they have left the room and moved on to the next patient?
In our ideal world, we would be doing collaborative visits all the time. The reality is that the clinic flow happens and somebody goes in and sees the family, identifies a concern. We also maintain a list, so we follow up with families. We know who we've seen before and who needs to be followed up on. And very often they've left the room. But what we try to do when the providers have left the room is really bring them back in for the treatment planning, for the recommendations, and it's critical for us that the families see that we are a team together and that these decisions are made collaboratively. And we have asked providers to come back in the room, depending on the case and depending on what their schedule looks like.
Can you speak more about the screening tools and process you use, and also more about the outcome assessment strategies?
Yes. So right now we universally, excuse me, we universally implement developmental screening using the ages and stages. We do it at every well-child visit between 2 months and 5 years. And we also do pregnancy-related depression screening at every visit between birth and 4 months, up through the 4-month visit. We have a green piece of paper, is the only way I can describe it, that screens for psychosocial factors and medical legal issues that families complete when they check in, and it asks about things like family violence and educational issues. Even though we have had for years now an integrated behavioral health program, we have not yet implemented universal psychosocial risk factor screening. We tend to do that on an as-needed basis or when red flags come up with the green piece of paper. And actually one of our goals for 2014 is, both in our clinic and in our community pilot clinics, to use one of the measures that's been out there already to screen. I would say about screening is that it's really much more than just implementing the screener. It's thinking about the processes. So the kind of implementation and launch that we did with both pregnancy-related depression screening and developmental screening had everything to do with getting provider and staff buy-in, educating families about why we were asking them their questions, and then making sure that people actually looked at the screeners. So initially we were finding pregnancy-related depression screeners kind of lying around unscored and unchecked, which meant that nobody talked to the families about them. And we've taken that all the way to building templates in our electronic medical record to help cue providers about what to do when there are particular screening results. And the next step for us is really what I call closing the loop, which is resulting the referrals that are based on identification using these screeners.
Great. And we're out of time, so we have a few more questions. Do you have a few more minutes to stay on to answer the questions? Okay.
I'm happy to answer.
Wonderful, thank you. So our next question is, how do you manage risk and liability issues in terms of psychopharm consults?
I'm sorry, I should have said this. We have a team, and the slide was so small with all of our people. We don't, the psychologists and trainees don't do psychopharm consults. We have psychiatrists who are on our team. The psychiatrists are present We have now coverage 4 half days a week and work with the primary care providers. And what we have actually is a model where, depending on the year of residency training, there are a different number of slots that are joint visits with a psychiatrist and the resident to address, it's not just psychopharm issues, but behavioral health issues, and then psychopharm management. And those slots change, so and the way the visits are done change depending on the year of residency and experience. And we also have elective blocks where residents who are going into primary care who want more exposure to behavior development and psychopharm can spend more time with our team members. So we don't prescribe, we really support the primary care providers to practice psychopharm within their scope of practice, and then we do our training and education with the pediatric residents in conjunction with our psychiatrists, who are also available then for consultation for our families.
Next question. When you use the Edinburgh to screen mothers and treat for maternal mental health problems, how do you document this in the child's chart?
We built in, it's a great question. So as I said, we don't bill for maternal mental health issues. The Edinburgh that we use, we changed the top of it, and it says, "And how are you doing?" And we really very intentionally use it as the start of a conversation around maternal and paternal and family well-being, directly impacting the baby and what's happening in terms of child development and well-being. So we have a pregnancy-related depression screening template that is documented in the child's chart. And when our clinicians do their consultations around pregnancy-related depression, we document that consultation directly relating parental well-being to infant well-being. And I'm told that in Colorado, starting in January, we will actually be able to bill for pregnancy-related depression screening and get reimbursed.
For maternal depression in the 0 to 3 group, if you're not doing psychopharm, is it just support and guidance? How often do you follow up with these moms? Do they need a suicide hotline, additional supports?
So we are not doing psychopharm if, depending on the screening results and on what we find when we go in and do our assessments, there are certainly women that need to be referred for urgent psychiatric care. And so we do that. We have actually a pregnancy-related depression support group program here that is not in our clinic, but that we refer moms to. And there are actually a number of other resources in our community that we would make referrals to. What we do is, for the women who are endorsing symptoms of distress secondary to being in the postpartum period, we will follow them much more closely. So we make the referrals that we need to make, and certainly any signs of emergency mental health needs, we would put someone on a hold or send them depending on safety issues. And we have actually transported mothers from our primary care clinic to the emergency department for psych evals when we've been concerned about safety of self or harm to others. So we would do that, and then the services that we provide are really very close follow-up and monitoring in our clinic, where we have the ability to schedule that family in. So maybe the next visit would be the 1-month visit if they're coming in at 2 weeks. But if we want to see them the next week or even later that week, we will get them to schedule a follow-up appointment with their primary care provider and check in with them. And we also do a lot of phone follow-up around pregnancy-related depression.
Great. And we have 2 more, hopefully, quick questions for you. Thanks so much for staying on a little bit longer. Sure. What screening is used for depression? We use the PHQ-9 on the adult side and would like to know what's recommended for pediatrics.
So it's a really good question. I think there are several different options, all the way from the PSC-17 to, if you wanted to do, there's the teen screen, which is just like the PHQ-9. I think we've actually in Colorado been able to get reimbursement for that as well. And then we don't do any of the specific screeners that I would use as a psychologist. So the strengths and difficulties questionnaire is another one that would allow you to look at some depressive symptoms in childhood and is available. It's in the public domain and available in lots of different languages and for lots of different ages.
And our final question for today, has anyone solved the same-day billing barrier?
So I don't know about anyone else. I was told very specifically by this medical director that I raised that issue. I said, well, you're saying I can bill, but I'm billing from primary care. And he said, I am not, and I think this is because we have capitated mental health. So I have to preface it with that. But he said, I'm not going to know if that child was seen in a primary care setting. All I see is your billing. So I think when it's capitated, it actually is probably one of the opportunities with capitation that I have not yet taken advantage of. But I think that that is a major issue. I would say we may have more data. I hope to have more data very soon on whether these counseling codes that are billed through the medical side really help us eliminate the same-day billing issue.
Great. Well, thank you so much, Dr. Talmi, for your presentation, and thank you all for joining us today. Our next webinar for January is on social media in primary care practices. Thank you.